Well, good evening to our audience. I am State Senator Gladys Robinson in my sixth term in the General Assembly, and I want to welcome you to this important discussion on implications of COVID-19 on communities of color. The year 2020 will be remembered by most of us as a year of great loss from an epidemic no one saw coming. Loss of life, loss of health, loss of family, loss of job, loss of school, loss of play, loss of time with family, friends, and loved ones, loss of vision, but not loss of hope. Today in our discussion, we intend to focus on the challenges and the changes, but because of our history as people who are overcomers, a community of color, we always rebound through challenges with hope and resilience. We welcome you to this discussion with our experts, those in our community who know you, who work with you, but who have great knowledge, who will share their perspectives this evening on the challenges of COVID-19 on communities of color. And they will share some recommendations for the future when epidemics or disasters may occur again, but especially on the overall issue of health disparities. We ask that you as an audience put your questions in the chat, and we will select from those questions as we have time to address. The others, you will get the answers later. Our panelists for this evening's discussion have a wealth of knowledge, and I'm going to share just a little bit about them. You can read about them on the website, I'm sure. First, I'm going to go in the order of women and men. I'm an older woman, so you know how I do that. Dr. Charlene Green is the current president of Old North State Medical Society that was established in 1887 to advocate for better health outcomes for African Americans and vulnerable populations in North Carolina. She's also a first-line essential worker advocating for North Carolinians as an anesthesiologist and chief of anesthesia. With her practice, her private practice group, Anesthesiology Consultants of North Carolina in Greensboro at Cone Health. She is also co-chair of the NCDHHS Testing Surge Work Group and was chair of its sub-work group, Testing Strategies Vulnerable. Dr. Michelle Laws is Assistant Director for Community Support Services and Community Stakeholder Engagement. She's also Council Chair of DEI in the Division of Mental Health, Disabilities, and Substance Abuse Services, where she has a wealth of experience. She is the lead for DHHS's Historically Marginalized Populations team dealing with COVID-19. Ms. Sharon Goodson is Executive Director of North Carolina Community Action Association. She is a tireless community leader and advocate, committed to improving the conditions for low-income North Carolinas for more than 25 years. And finally, Mr. Ben Money. Ben is Deputy Secretary for Health Services at DHHS. His portfolio includes the Division of Public Health, Division of Health Services Regulation, the Office of Minority Health, and the Office of Rural Health. Prior to joining the department in July 2019, he led the North Carolina Community Health Center Association. Mr. Money's 37-year career in healthcare began in community mental health and includes 11 years in local public health and 18 years with community health centers. What happened to my screen? What happened? Now, we will move directly into questions, and I'm going to ask our panelists if they will give a short opening statement regarding what they see as challenges that our communities have faced during this whole COVID-19 pandemic. So we'll ask each of you to give us an opening statement, and we'll start in the same order. Dr. Charlene Green.
Yes, thank you, Senator Robinson. So it's been a long 2020 and it's going to be a long 2021. I've had the pleasure of working with Deputy Secretary Money as well as Dr. Laws with the historically marginalized population, and they've been working tirelessly to try to figure out how do we target better the vulnerable population. So some of the challenges, are particularly that you have to know our communities, and the vulnerable population needs to be able to trust the communities, community leaders, so that when you come to them and try to support their best interests, they know you. So that has been one of the challenges that, the community physicians are the ones that have been talking and knowing these patients for a long time. Many times they've been excluded in this process where they have not been able to have the tools and the resources to give the information to their patients as well as provide the needs. So that will be one of the challenges I think that going forward we may need to address. But I'm looking forward to figuring out some better strategies, particularly to get to the African-American males and some of the younger population of how do we target them better. We have some great ideas based on some of the committee groups that we worked on. We just need to implement them.
Okay, thank you. And we're going to move right to you, Dr. Laws.
Thank you. And again, it's an honor to serve on this panel with all these esteemed panelists and with you, Senator Robinson. I think the biggest challenge that I see is the mental health implications and consequences of the COVID pandemic. When you think about, according to the Economic Policy Institute's data, 30% of African Americans in North Carolina are unemployed. When you look at data that shows Black workers in North Carolina, 30%, more likely to be unemployed than their white counterparts. When you look at the data in terms of the kids who have lost learning and who are dealing with the stress and anxiety and other mental health implications of trying to learn in a new environment, especially kids that came into the pandemic in that educational and academic achievement gap. When you look at the evictions and the mortgage losses and just all the socioeconomic indicators and see the disparate impact, I think mental health and substance use disorders is perhaps going to be our next wave in this pandemic that we're currently in. I believe we were in it early on in the pandemic. And so I think addressing the mental health needs of the Black community as well as the Hispanic community, but certainly the Black community, is going to be a challenge, but an important one that we must meet.
Well, and we thank you. We are going to ask you to talk a little bit more about that later on. Ms. Goodson.
I really want to just piggyback on some of the comments that have already been made. And the big one is trust, particularly in communities of vulnerable populations, communities of color, trusting the information. There's been a lot of misinformation out there. So we have to really work hard to ensure that we're not just talking to, but we're talking with our communities to make sure that they are getting information from the right source. The other thing too is mental health, because in our space, we are working with families who were already stressed out before there was anything, before we even knew anything about the coronavirus and COVID-19. And so we really have to do more, stressed out, just totally stressed out. And so we've got to do more to help meet the needs of vulnerable populations. We've got to bridge some gaps and we've got to have some strategically targeted resources that help these families with mental health, help them to get on their feet. And so really we have a lot of challenges. We want to do our part in helping to meet this challenge and to serve this population.
Okay, thank you. Mr. Money?
Yes, thank you, Senator Robinson. And, we're really in a race to vaccinate. Since the beginning of the pandemic, we've seen 955,000 total cases of COVID-19 in North Carolina. 21% of those cases, 165,000, have been African Americans. Our population, a percentage of the population, is 23% in North Carolina. And right now, we're seeing the percent of the positive cases fluctuating between 4.9 and 7%. And then when we talk about deaths, there's been a disproportionate number of deaths of African Americans compared to the overall population. Of the 12,505 deaths, 25% have been African Americans. That's higher than the percentage of our population. And one of the things that we're seeing is case rates for African Americans are going up in all age groups below 50 years of age. And the most significant increase has been in the Triangle, the Triad, and the Charlotte areas, in the urban areas. And these are the largest disparities in African American case rates since the beginning of the pandemic. This is the largest point of disparity right now. One of the things we're also seeing is that there's, for African Americans, an increase in rates in rural and suburban counties. But again, it's those urban counties and it's the younger population. The 18 to 24-year-old African American population is the highest in all regions. This is really what Dr. Green was getting at. We got to get to the younger people. We're not seeing this in the white population of the same age. We're also seeing it in Wilson, Nash, and Edgecombe counties. So again, not urban counties, but these are rural counties with higher proportion of African Americans. And one of the reasons why we're in this race to vaccinate is that we're trying to get ahead of the variants. Right now, the predominant variant is that UK variant, that B.1.1.7. And there's also the B.1.351, that South African variant. It's rare, but North Carolina actually has the most of those variants. So the race to vaccinate is really about getting ahead of these variants. Right now, 6.7 million vaccine doses have been administered in North Carolina. 3.2 million people have had at least one dose. And of those, 17.4% have been African Americans. So, falling behind the population norm, we started out behind right out of the gate. We were less than 10% at the very beginning. Mm-hmm. And I'll talk later about the intentional efforts we made to move that closer towards the population average, but we still have a ways to go. But overall in North Carolina, 47.5% of the adult population has had at least one dose, and 36.8% are fully vaccinated. So that race to vaccinate is the key thing for us right now.
Okay, so thank you. Let's kind of follow up with that. Dr. Green, since you've been on in this testing, tracking, surge group, and I know your organization's helping with testing and the vaccination, how do we address that in terms of that younger age group? Older folks obviously were the first to get out there and, after a little hesitancy, if their friends got a vaccination, they got it. I know mine did. So, but what strategies or what are we talking about doing to address that?
So what we talked about with the subgroup of the vulnerable population long ago is that you have to go where the vulnerable population is. You have to go to their communities. You have to touch them. More importantly, you've had to have had the experience of knowing them way before now, because you just can't go into a community and say, hey, this is what I want to do. You've had to build a relationship with them. So many of the organizations, just like Old North State Medical Society and other many grassroots organizations have done that. That's what we need to do. And that's what we're doing now. Going out into the communities, going out into the nursing homes where some of the workers can come out and get tested and get the COVID vaccine. They know you, they've seen you before. Go out to the migrant farm areas, go into their trenches where they are with mobile vans or smaller units where, bringing in some other trusted members of the communities that can go with you that know them as well, and have them get the vaccine and get COVID-19 testing. They have to feel as though you have to, know them and trust them. In addition, I just want to always add that particularly, some of the population feel as though they're being targeted and so they've not been able to get the care that they need, such as the Latinx community many times are afraid of getting, targeted by ICE. We have to figure out how to protect a lot of these members so that they can get the help that they need, the vaccines that they need, and the COVID-19 testing they need, and give them that space of protection. So that's one of the other things. But going to the granular areas, we know where they are. You got to go to the housing project. You got to go sit outside. You got to know and touch people. You can't do these virtual things and have these TV ads and say, hey, come and get vaccines. That doesn't work. You have to go where they are, and they have to have seen your face way before then.
Well, thank you, Sharon. Let's move to you. I tend to call everybody by first name, so if I flip that, y'all understand.
You're fine.
But you work in rural and marginalized communities. So, what's working or what's not working, or what do we need to do? And you talked about some myths the other day. So tell us what's going on.
Yeah. One of the things, and as I said before, when COVID-19 hit us many months ago, it literally turned everybody's world upside down. And as I said before, we know that the greatest hit on COVID was to marginalized and underserved communities. Those are the families who were already struggling to try to keep a roof over their head. They were struggling to put food on the table, to pay for childcare, and often had to choose between whether it was food on the table or medications. And so community action agencies have been out in the community for nearly 60 years. There are 34 agencies here in North Carolina, 1,000 of us across the nation, serving 99% of the nation's counties. And we realized that, we've been around a long time. When you start getting close to 60, you kind of dated. So we're kind of dated. So we realized that we needed to pivot to be able to help these families, because it was different from how we had, how we'd normally done things. We had to rethink everything. We weren't the most, the older ones of us, and I hate to use age, but, we weren't as technology savvy as we needed to be. But guess what? COVID has forced us to be that. So there's some good things that have come out of the pandemic. And so, we went from doing face-to-face conversations and holding folks' hands and helping to lead them through their life plans to having to do a lot of work via the phone, a lot of application and processing from online, Zoom, and using all kinds of social media platforms, using drop boxes so that they could drop their documents in a drop box and we could safely, because this virus is contagious. And so that we could safely and securely exchange information and those kinds of things. Our case managers and our program folk, they get to know their people. That's the big piece. The biggest challenge that we have is trust. And so I do believe that is an advantage for our agencies and our network, because they live in the community. They live, they work, they play, they learn there. And so, our folk have always worked with these people to help them to connect the dots to be able to get the programs and services that they need. And so when we look at this, what COVID did was it significantly revealed some of the stuff that we already knew, people who work with vulnerable populations, about food insecurity. It revealed that it was the most significant thing in our state and probably across the nation. And so, we had to work to ensure that families had access to food. Our Head Start programs were delivering food in their vans and buses to their Head Start children. CAAs were delivering packaged meals to seniors. And, they coupled that as a wellness visit because we wanted to make sure we could leave it on the porch for Miss Daisy, but Miss Daisy, we could see that Miss Daisy was okay in her home. One of our agencies went as far as, because of the social isolation, when we talk about the mental health, and we've all experienced that. But for our seniors, they were doing parking lot bingo so that the seniors could stay in their cars and that they could see their friends and that kind of stuff to help alleviate social isolation. Now, one of our agencies, Action Pathways in Cumberland County, it operates the Second Harvest Food Bank. They were short-staffed. The challenge was, all the volunteers were gone. Nobody wanted to be exposed to COVID. Prior to COVID, they were serving 200 other food pantries across a 7-county region, just doing incredible work. Short-staffed, working around the clock. The National Guard came in, and in fact, National Guard ended up being there with that agency. They put in 25,000 hours of volunteer service to help get food out to people. And that service was valued at more than $600,000. Our agencies have helped keep people in their homes so that they wouldn't be on the streets, running the HOPE program and working in partnership with the folk with the NC HOPE program, providing mortgage assistance, rental assistance, utilities. I mean, you name it. We realize our mission is anti-poverty work. And if we can show up in this game, we need to shut down every community action agency, not just in North Carolina, but across the nation.
Yeah. Well, thank you. Thank you. You've got a wealth of work and knowledge, and we appreciate that. We really do. So, Dr. Laws, if, as we talk about that 18 to 24-year-old, one of the things that occurs to me is that one of my godchildren had a reaction and was vomiting and all kinds of stuff, found out there was nothing wrong with her. She had taken the J&J. And obviously, there was some issues going on. Talk about maybe some of the emotional challenges, especially that age group may be facing, that may keep them from wanting a vaccine or acknowledging it's a problem. Talk some about that and expand it if you want.
Certainly. So I will do my best. Adolescent health is I know just enough. Hopefully I won't be dangerous with what I share, so I often tell people that life it came to a standstill in many ways in terms of being able to access services, being able to do certain things the way we normally did. But people continue to grow. People in terms of aging, people continue to age. And the same challenges that life went on in a lot of ways, right? And the same challenges that adolescents and young adults was dealing with, they were compounded by this or exacerbated by the effects of COVID. And so when you've got young people who are already vulnerable to emotional states and don't have the tools, the wherewithal to process certain things in certain ways, and then you add on top of that anxiety about this pandemic and about their lives being interrupted, you're going to have, people experiencing different emotional distress. But it's not just young people. My husband got the J&J vaccine. 3 days later is when we paused. Well, actually 2 days later is when we announced the pause. And everything that's been bothering him since, he's blaming it on J&J. And he didn't go as far as saying, you're trying to kill me, but he was like, you told me to get this thing and now you all are. So think about how emotional we are. And we have tools, we have knowledge to appraise that trigger, whatever it is. Young people don't have as much of many of the tools that we have. And that's why it's important to make sure that depending on how serious or severe it gets, that they're linked to services. And I'll talk later about stigma and about how we as a community, we are in no position at this point to stigmatize mental health or stigmatize substance use disorders, because it is really going to be, I think, like I said, the crisis that's right in front of us everywhere we turn. So on the emotional side, I would just say that's not uncommon. The key is to make sure that there are services available and that we're directing our young people to the right services. Suicide ideation is up among young people. And we know we're seeing upticks across ages in terms of substance use.
Wow. Wow. Yeah, and we want to come back to that. But while we're talking about J&J, Dr. Green, tell us, I want to say the real deal in terms of needing to get a vaccine or not. People want to hear, one of the things that I as a legislator dealt with in our community was really working with churches. And I know Dr. Laws knows a lot about that. She's done a lot of that work so that people could hear the encouraging word from the pulpit, from the pastor to say, okay, I'm going to get it, you're going to get it. But still a lot of people were very hesitant and still remain. And then the whole thing about J&J now. So tell us and tell this audience, what is the real deal on this and why should they get the vaccine? Not the J&J now, but why they should get a vaccine.
So I'm just going to be really real with everybody. This whole process of how we have dealt as a country with everything has been an epic failure. All the hesitancy, we didn't get the messaging out maybe in May or June of last year. We should have been talking about vaccines in May or June. And that's the federal response, the state response, anybody response. And so I'm going to say that we have almost close to 600,000 people dead in the United States. The cutting edge technology, messenger RNA vaccine, which is the Pfizer, and Moderna, has been statistically proven thus far. Of course, there are ongoing studies that show that it has decreased significantly deaths and hospitalizations. So for the people out there that are thinking, hey, I'm afraid of this virus, afraid of this vaccine, I'm afraid of the side effects, very few people have died from the vaccine. But 600,000 people have died from COVID. So when you think about the pros and cons, everybody doesn't want to tell people, mandate what you should do and should not do. But look at the pros and cons of if you should take it or not. So I do personally tell people they should take the vaccine based on the data that's come out through NIH and CDC. Old North State Medical Society has been working closely with Dr. Stefan Wallace from the NIH. He's been in our ear the whole time, helping us with webinars, helping us with data, and as well as Dr. Rashid Naji from the CDC. I think he's moved up with some of the more important work, in the administration. But the bottom line is that people want to hear answers to their questions. So a long time ago, the NIH and CDC was basically saying, stop all the virtual talks, stop all the webinars, and send out FAQs. Send out, so you see on our link with Old North State Medical Society, we update many times the NIH links, CDC links about like the new things that are happening. Most people are afraid of, many of the young people are talking about infertility, or they're talking about, what will happen if I get pregnant. So you answer many of those questions, many times they will come and get the vaccine. So the answer to your question, the pros and cons is the vaccine will save your life and it will help you not be in a hospital. You do not want to be in the hospital. And I cannot be in this space without telling you guys, when we peel back all the information about what's going on, you're going to see this has been more horrific than you think. Mm-hmm. So there are many, many unreported deaths that you don't even know about, such as in the hospital. I know Dr. Laws is talking about suicide ideations. I see suicides.
Right.
And people that I would never have thought about before. I see, blood clots and brain clots and strokes from people that are 20, 40 years old that nobody's talking about, right? So when we get to that data from NIH and CDC in about a year, you're going to see that this is more horrific than you think it is. I see it all the time. So I want to share that with you guys. I also want to talk about what Dr. Laws mentioned a minute ago was inequity in healthcare. So we've been so focused right, on just getting the vaccine or testing, that, that's been the one thing we've been talking about. But the whole process is, you got to look at the whole patient too, just like everybody's talking about. Food insecurity, people are hungry. People, don't have jobs. People are, like you said, are being evicted from their house. But more importantly, they're not getting the health care they need. Now they've been a year or 2 years with big lumps in their necks. Now they got stage 4 cancer, for lung cancer, colon cancer, because long time ago, people were, wanted to say, stay away from me. Don't come to the hospital. Don't come near me. We just need you to get tested. So that's inequity in healthcare. So in the future, Senator Robinson, when you were talking about like, how do we get this better? We got to have the bandwidth, and we have the bandwidth to figure out how to do multiple simultaneous things at the same time, so that when you peel back what's going on, you can help in all these different capacities. The last thing I want to say is, Dr. Laws, one of the things I hope that the policymakers on this call can really do is fund mental health. We talk about how people are having all these problems. Where is the funding? You can't even go, if you go to the hospital now and someone is having a mental crisis, you know what happens to them? They get seen maybe in about 5 hours in the emergency room, but there's no place for them to go. There's no funding. They go back out to the street.
Okay.
So and the majority of, so when George Floyd in substance use and mental health, in need of substance use and mental health treatment. So when the condition manifests itself, when someone is declining in their recovery, and they're out in the streets, and they happen to be in our society, in our country, if they're African American and police are called and they are in a mental health crisis, we know how the story ends. The outcome is more likely to be fatal.
That's right.
And when Dr. Green said, and then I'll be quiet, but I just wanted to
go ahead.
Thanks. This is our country's Katrina. This isn't, Katrina happened in the Mississippi Delta and in the Delta area. But COVID has happened all across the country. When the waters recede, when the levees broke, then the waters receded, they saw where all the dead bodies were, they saw all the damages in terms of housing, they saw it illuminated the inequities. When we get people vaccinated, when we see a decrease in the numbers and we can now shift our focus, we're gonna see, just like when the waters receded after Katrina, we're gonna see again, not just high rates of deaths from COVID related, we're going to see, as Dr. Green mentioned, those other chronic health conditions and diseases that went unattended.
Absolutely.
We're going to see homes that people couldn't come back to because either loved ones had died, and I'm thinking now about our folk re-entering our communities from our prisons who were dependent on grandma to be there because he didn't burn all his capital with grandma. Grandma said you can come home, but she's gone. And in our communities, that's more likely how it happens. And Dr. Jim Johnson schooled me on this about people say that the Latinx and Hispanic community is all about family. And he said, we are too. We're multi-family units too. We have multi-generational units as well. And so there's just going to be a lot of, once the waters recede, and they are now, wreckage that we're going to have to repair or build back stronger than what they were before going into this pandemic. People not being able to mourn and grieve loved ones who've died. Churches closing down, and so we may have seniors that go in one area where there's innovation happening. Sharon Goodson is an innovator. She figures out how to, like our folk tell us, our ancestors tell us, take a little and turn it into a lot. In church, they say little becomes a lot when you place it in God's hand. Well, we have known how to make a way out of no way. Mm-hmm. And So there are innovators, but think about those who have not been. And the social network for seniors was what? Church. And so when they couldn't go to church anymore and they couldn't figure out that darn Zoom thing, they've sat in isolation and their mental health has declined. So I just wanted to sort of echo and add to some of what Dr. Green had said.
And that's a good pivot and a good lead in too, because what I think we need to want Ben to talk about a little bit is the department's talking about social determinants of health. And, health disparities, we know I'm a community health practitioner for 45 years, been around, but Lord, we just get sicker and they've redefined it. So what in terms of these social determinants, what in terms of health disparities being, because all of these panelists have talked about all of the ugly stuff that's already there, that's been covered up by COVID, and now we see it. So what strategies, what are y'all looking at in terms of how do we take a different road here?
Well, that's a really important question. We saw this play out at every stage of this pandemic. I talked earlier about the case counts that, have widened to the greatest degree since the beginning of the pandemic. And, the vaccination effort we see is really the way out of this COVID crisis. And it's important to remember that we just began vaccinations in mid-December. And up until just last week, there was more demand for the vaccine than there were supplies. I think that notion of, people of color being hesitant towards the vaccine, there were more people of color wanting the vaccine than there was hesitancy. And the thing that we found was that we had more providers that were vaccinated providers that were ready to receive vaccine. We had vaccine available. And so what we had to do was, and this is what was done throughout the nation through CDC and their advisory committee on immunizations, the FDA really laying out a framework, excuse me. And so we use that framework, working with the North Carolina Institute of Medicine to develop a 5-step prioritization. And that was based on a person's risk of exposure to COVID and the risk of severe illness and death if they contracted COVID. And we also knew that unless we had good data on who was getting vaccinated by race and by ethnicity, then we weren't going to be able to demonstrate whether we were getting vaccines into the right places. So early on, we had an option of signing on to the federal government's vaccination data system or building our own. We knew that if we signed on to the feds, we'd have very little say-so as to how that system was developed. We chose to go our own way and built a system, that CVMS system, that actually requires race and ethnicity as data fields for a vaccine administration to be submitted. And one of the things that we found was it gave us the kind of data that most states did not have. We've got like over 95% of the vaccine data, including race and ethnicity. So we could see the truth. And one of the things we found out from the very beginning was that federal emphasis on speed, getting vaccines in the arms, led to great inequities in terms of who was getting the vaccine. Mm-hmm. So you talk about these social determinants of health. One of the things that we saw it in education, and we saw particularly in vaccine access, was whoever had internet access, whoever had speedy internet access, whoever had, the ability to call on multiple phones when appointments for vaccines were scarce, and hold the line until they could get an appointment in this county, in that county, in that county. And then whoever also, once they got that appointment, had the transportation to drive from a wealthy area of North Carolina to a poor area of North Carolina to jump the line in front of people of color to get a vaccine, got the vaccine. And so early on, we saw that less than 10% of the vaccines were going to African Americans. And so we use that very same data, that same strategy to really focus and lean heavily into equity. So we use that data to allocate vaccines to counties that were under-vaccinated and also measure the equity performance of every one of our vaccinating providers. How were they doing in their community to vaccinate people of color? So if in their county, 35% of their residents were African Americans, were there vaccines that we gave them going into African American arms to the at least the extent of 35%? We also implemented a process of utilizing case managers. So in the course of our vaccine week, where we were getting vaccine to providers and they were getting it in arms in the course of a 7-day period, if we had providers that weren't vaccinating on an equitable basis, we would transfer those doses of vaccine to providers that could. Right now, we're at a point where we're able to give vaccine to all the providers that request it. And so our goal is really to make the vaccine widely available. So you're seeing more same-day walk-in appointments. You know, we early on set up a helpline at DHHS. Now that helpline, which, you know, has multiple languages, live people answering the phone, can actually help people get appointments. We were also focusing a lot on utilizing data to really drill down, not just at the county level, but now at the census tract level, as to where census tracts have high what's called social vulnerability. So we use a social vulnerability index on the census tract map all across the state. We're going to be releasing this map on Monday to the public. It will show 96 census tracts across the state where SVI is high and vaccination rates are below 15%. The other thing that we're doing is we're working with our network of over 450 community health workers to educate community members about their questions, their concerns, connect people to vaccine appointments, help to facilitate community vaccination events. And these community health workers are majority female and a majority people of color. And throughout the pandemic, they've been critical in our efforts to help people, particularly essential frontline workers and low-income families, during a period of time when they've been asked by the health department to isolate or quarantine because of their COVID exposure. So these community health workers provided vital resources like food, connection to primary care, personal protective equipment, and COVID relief payments so that these families weren't forced to break their isolation orders to go to work and then risk infecting others. We also made sure that they were paid a living wage. These community health workers were paid a living wage for their service in risking their own health to serve their community. We're also in the process of expanding on this effort through our Healthier Together Health Equity Network that has launched in partnership with NC Counts Coalition. And just Tuesday, we released an RFP for community organizations where we're going to be working with NC Counts Coalition to give out over $500,000 to support efforts at connecting community members to vaccines, to hosting vaccination events, to educating communities, to that kind of messaging that Dr. Green talks about that comes from communities to communities. We're also at DHHS creating a new secretarial office of health equity, and we're currently recruiting for a chief health equity officer position. Just to kind of round this out, one more thing, we are preparing a CDC equity grant to build resources and particularly build up our data capability. I'm going to talk about this later, to measure programs for their effectiveness in closing equity gaps across DHHS.
Okay, thank you, Ben. You gave us the roundabout. That's good. So we're going to move quickly so we can get a couple of things. And I want to know that most of our audience are elected officials. Mm-hmm. These counties either got PPP money directly from the state or from the federal government, a lot of different pots, housing, daycare, public schools, et cetera, et cetera. So what I want you to talk about, all of you talk about, is hearing the challenges and knowing that we still have a huge population there not vaccinated, whole population, Sharon and Michelle, who are in need of mental health, food, everything. Tell these elected officials how they can best think about using funds that they have, they'll get from the state or whatever, to help to resource communities of color in their communities. How can they better help? And you can join in too, Dr. Green, but I want to start with Sharon a minute. And then all of you round into that, and everybody keep it kind of short now. Okay.
One of the things too, I wanted to piggyback a little bit on what Ben was saying too. Most of our folk are essential workers. And so, when you do no work, no food. And so, and when we look at that, they don't have the luxury of being able to work from home and those kinds of things. But we have to look at what we're paying people and the kind of benefits and things like that. So ask any elected official to trade places with a poor person for a day, just to walk in their shoes. And we see it all the time, and there are misconceptions. These folk prior to COVID, they're working 2 and 3 jobs just to try to make ends meet. So we've got to do some stuff. We've got to target our resources. We all want to move people out of poverty. And that's the big thing. And so when people have the resources, they can take care of themselves with all of these preventive methods. When we talk about fresh fruits and vegetables and organic and all of that, they can't afford that. They got to go through the McDonald's drive-through just to be able to feed the family and those kinds of things. And so we've got to think about the folk are hurting. And I think we take for granted when we can get up and we can put some gas in our car and we can roll around wherever we want to. Most of these folk got $10 to make it that week till they get that next paycheck. And we know some of the challenges right now, everybody's not back at work. While they go to work, the kid gets COVID or somebody at workplace gets COVID, everybody's got quarantine. Why folk don't get paid when they don't work? And so that's a problem. And so we've got to look at addressing those kinds of issues. We've got to look at one of the things we got to do. First of all, we got to talk to these people. We have to value the experience of underserved populations. When we do any work in our work, when we pull people together and we pull vulnerable populations together here recently, and as we do this work, their time is more valuable than our time. And we'll pay a consultant $50,000 to do whatever it is he says he can do for you. And we don't want to give a poor person a $20 gift card to even sit down at a meeting table to talk to us or provide childcare so they can participate in the meeting. We have meetings and stuff all during the day where these folk don't have access. We need to figure out how we can create some access so that people that have that kind of voice, their voice is valuable. And it's lived experience that we have to learn from. Poor people are the experts. We're not. So we listen to them. We value what they have to say. And that's why we're launching this campaign too. I want to mention that because they have been so disproportionately hit with COVID, and they believe a lot of them through social media, all these myths. We're launching Sleeves Up North Carolina in May, and as one of the things that we're doing for Community Action Month to dispel some of the myths, because we want to get as many Black and brown people to get their shots in the arm, get vaccinated. Shanae and Bebe hadn't seen themselves in anything that we put out. And I know we did some good work in the state, but we work with the Shanaes and the Bebes, and they have to be able to identify. It has to be relational. Right. They got to see something. So we've teamed up with Chris Wilcox, a former NBA player. And so we have some caricatures that look like Shanae and Bebe and Papa and Big Mama. And guess what? He's going to dispel some of these myths. This thing came out too quick. It's been vetted for a long time. It had a lot of advanced work already done. So it's been vetted, those kinds of things. When we listen to Uncle Bubba at the cookout telling us, and Uncle Bubba, he's couch surfing. He sleeps from sofa to sofa, but he says why you shouldn't get the vaccine, and we listen to it. So we have to continuously put out facts and we have to continuously engage our communities. They have to be at the table, and they have to be a valued voice at the table.
Amen. Amen. Go ahead.
I'd like to the elected officials out there that can make decisions about funding. I want to say first that we know the educational achievement gap has widened between Black and white children. McKinsey and Company released a report where they did some simulations, and they found that if their simulations hold true, their model holds true using data from 50 states and from different educational databases, overall, Black kids will have lost in the 1 year of the pandemic, 10 months, compared to white students who have lost 6 months of learning in the classroom, and Hispanic students 9.2. Low income kids 12 months. And we know that back in December, the likelihood, and they will have lost this as a result of disengagement and lack of access, right? So the whole, digital divide and all that plays into it. And back in December, we saw some of this happening when we made national news. USU News and World Report reported that more than 10,000 North Carolina students unaccounted for. And so I would say invest in community-based programs that are helping to bring our kids back on track academically and educationally. Saturday academies. Summer school was fine, but kids are going to need that. They're going to need a break. They're going to need some time to enjoy themselves too and to relax. And so investing in Saturday academies, investing in tutors, similar using Big Brothers, Big Sisters model or Teach for America, making sure. So we need now to reinvest in those kinds of programs and inundate low wealth, low income areas and communities, and particularly tailor these programs to our kids. So using our students that are graduating from programs in the at HBCUs and other schools. The other thing I would say that they should do, Blacks and Hispanics and young people and low wage workers have been hit the hardest in the housing crisis. Brookings Institute released a study that you can find that looked at the economic impact by race and ethnicity groups. And he found that eviction and foreclosures experienced in the past 3 months during the time frame that they looked at, so March through May, and then June through August of last year. So in the pandemic, African Americans were more likely and Hispanics to have faced eviction and foreclosure than whites. 5% of whites during that time period, 9% of Blacks, and 11% of Hispanics. So invest in some housing policies. And then in terms of rent and mortgage delinquency, 16% Black, 17% Hispanics were facing mortgage or rent delinquencies, even in the moratorium on evictions underway or in place, and that's compared to 9% of whites. So invest in some housing policies to save the homes of people who they didn't have the money 3 months ago. They definitely don't, 12 months ago, they don't have 12 months of back rent and 12 months of their foreclosure. So they don't have it. And so, to prevent an increase in homelessness, to prevent an increase in the trauma that comes along with children having to move and having to sleep on people's sofas and having to, invest in housing policies that will mitigate some of the effects of that. And then on the wage piece, the latest data released March 21st, showed that the Black and white gaps widened in terms of unemployment rates, and the Hispanic white gaps persisted or stayed stable. In North Carolina, 9.1% unemployment rate among Blacks compared to 6.8% among whites, and the general unemployment rate in North Carolina, and this was looking at data back in April, February, the report was released in March, so it was quarters 3 and 4 of 2020 data that was released and published. And so, so we know that we've got to do something to mitigate the economic impact. Now, whether that's small loans, whether that is putting some money aside to actually pay off the debts of people, because they're not going to be able to do it. They're not going to be able to do it. And then lastly, the mental health. Invest in crisis-based mental health services in your communities, use multidisciplinary teams. Don't let the law enforcement be the first responders out in a mental health call, and think about trauma-informed care and treatment, because this is what this is. This is a traumatic experience, multi-layered traumatic experience.
Okay. You see, we could take 2 hours. I want to get to you, Dr. Green, and then I'm going to allow you all. We close at 7, so we don't have the 9 minutes. But this is a great panel, and it's a lot of information for you to share with our audience. So you had some comments, and then enter into what you consider what your one recommendation. I'm going to ask each of you for one recommendation in terms of what we can do as a state or even local communities. So go ahead.
Yes, me.
Yes.
So mine is going to be a long sentence. I'm going to say that we need to reimagine the public health system and hospital system of metrics and accountability. And I would suggest before we decide on how we're going to spend money, have a commission of experts, including people like Sharon Goodson and grassroots organizations, of knowing what is the best way to spend the money. I'm going to say that hospitals, I work in a hospital, amazing places for many strategic things such as strokes, heart attacks, ECMO, and really intricate things like that. We need to invest in the community physicians, providers that actually own the preventative care space. Hospitals don't do a great job with preventative care, and it's okay. They have their space, they are great. Community doctors need to be able to take care of their patients and be able to help with that strategic care. So in equity in healthcare, I want to just make one other point of we need to have with those commissions in hospitals and in public health system, diversity in people at the table that can understand what to do with even something as simple as marketing. How do you market to the vulnerable population, and have people at the table that know how to do that and do it well? So that's what I want to say. And basically focusing on the social determinants of health. We're all talking about vaccines and we're all talking about testing, but people still have hypertension and diabetes. Where did that go?
Okay.
Right.
Okay. I'm going to let's stop. I want everybody to get a minute. I know this is a lot. You're right. Okay, Ben, go ahead.
I'm going to say one thing that hasn't been said, because I agree with everyone else's comments. I was checking them off as they were being spoken. This is one thing I think very practical that local elected officials can do right now, particularly with the federal money that's coming down. It made a difference in my life. I grew up in the 1960s, and I'm a product of the Summer Jobs Program. Summer Jobs Program. We need to make investments in our kids. That Summer Jobs Program, I still look at my Social Security statement, and the income I got from my Summer Jobs Program shows up on me. You know, it gave me a great opportunity to build life skills, to build a work ethic, to just have experiences showing up for work. Every kid should have the opportunity to participate in the Summer Jobs Program. With that money that's coming down, you could do a Summer Jobs Program starting right now.
Yes.
Sounds great. Okay, Sharon.
Well, I'm gonna tell you this, Ben, you're exactly right. And I just want to ditto what you said, but very quickly, as I said before, we have to have marginalized people at the table. That voice needs to be there, but it needs to be listened to, and not just at the table, but listened to as we set policies that impact their communities. Also, we need to prioritize where the distribution of resources. They need to be going to the communities with the greatest need. So we have to do that, and that's something that we can do now. But I do want to say this. We are working on a report with Dr. Jim Johnson that we will be releasing hopefully in June that will capture lived experience of our families and our neighbors, low-income families across the state, and how they've been impacted with COVID, how COVID has impacted their lives, because it has touched every facet of their lives. So we want to share that with you when that report is released. Thank you.
Good, very good. I look forward to it. Okay, Dr. Laws.
Money for mental health. And I mean, I know we are getting quite a bit, but we need probably 10 times more than what we're getting. Mental health and substance use services, really, and not just federal dollars, but single stream funding or state funds to invest in community treatment, community mental health services and programs. And also step down. We've got people in psychiatric facilities that are being released because there's no place to release them to. And so, and that is also, we also have kids that we can't find placements for. So they're in placements sort of as a holding place instead of in the appropriate settings. And so we need to make sure we are investing in mental health. And then I agree with everything that Ben and Sharon and Charlene has said, but I also would encourage us to invest in the justice involved population as well.
Yes.
Because they're going to be squished as we're trying to
Amen.
meet the needs of our vulnerable population.
So what I've heard and what our audience has heard are many challenges, not only physical health, but tremendous mental health. And we know that we've done a poor job in the state of North Carolina in addressing that. Terrible job. And so we want everybody to hear that we have to invest in that. We know that unemployment is high. People who didn't have jobs before definitely don't have them now. Those who had them have lost them. They were low wage, a lot of them, and didn't meet their needs. And now they don't have anywhere to go. Children are hungry. People are homeless. And so the situations have been exacerbated by COVID. But remember that we are people who have hope. We have hope because we fight the battles and we overcome them. Remember the story of David and Goliath. Consider us David. And as all of you are listening, think about your own inner strength and what it is you have to offer to the people around you while you're elected, while you're in that space. And what you can do to empower the folk around you, like Sharon does every day, as she goes out there, she pulls out communities and she says, yeah, you can do it. Now I'm going to help you, but I got to lift you up. And so we've got to lift each other up. I want you to reach out to the experts on this panel. They have a wealth of experience. They will come and see you. Michelle's all over North Carolina, in churches and everywhere else, and Charlene and her bands and all, and Sharon too. And Ben is an excellent resource. Ben in Community Health Forever. We have our own people who, and folks can trust folks who look like them, who understand them. And that's what we're about. We're about you trusting, but get people to trust you as elected officials. And let us not only handle COVID, let us handle health disparities. It's time to get rid of sickle cell and HIV and all of this stuff that hurt our folk. It's time to do something about quality of life for our people. I want to thank our panelists. We can't see your applause, but we know you're giving them a great round of applause, aren't you? So we want to thank them and we want to encourage them because it's a hard job, but we want to encourage them and we want them to keep on working hard now. And we pledge to you that we'll work hard as elected officials. It's been an excellent time with you. Please post your questions and the Black Alliance will get answers back to you from these experts. Have a blessed afternoon.